practice the content that I'm learning. I'm very much still a student, so there probably will be some mistakes. I'll try my best to, if I notice a mistake, fix it right away. But if I don't fix the mistake, you can always leave a comment below, just for clarification. I will be using this channel to mostly go over like science-related topics, and I really just love learning and I love teaching, and I think it's really fun. So yeah, let's get into it. Okay, so today I'm going to be talking about cranial nerves, and why they're so important and what they do. So there's 12 cranial nerves, and we're going to be going through all 12 of them, their cranial vault exit, their cranial nerve name, their function, and signs and symptoms of dysfunction. For anyone entering medicine, it's like super important to know. I'll also be sharing some like information about how I learned them, like helpful like mnemonics and tips and tricks. You can find most of them on the internet, but stuff that I found useful. And then I'll also be doing a video, I think, on the muscles of the mouth, like the oral cavity. I'm not sure yet, but anyway. Okay, so let's get into it. So first things first, there are 12 cranial nerves. So we're just going to go through them one by one. But first, I'll just give you an overview. So there's the olfactory nerve, which is number 1. And cranial nerves are written with Roman numerals like this. So that's 1. Looks like an I, but it is a 1. This is 2. This would be optic. And I remember that optic is 2 because you have 2 eyes. So that's a way to remember it. And then olfactory is 1 because, well, I don't really have a thing for that, but just remember that smelling, like, it kind of goes backwards in your head. So if you start at the front, like very anterior, if you're looking like in anatomical position, it would be your nose is like before your eyes, so your nose sticks out. So that's how you can remember olfactory is number 1. Okay, number 3 is oculomotor. 4 is trochlear. 5 is trigeminal. 6 is abducens. And the V means 5. 7, so that's 5 plus 2, so 7, is facial. 8 is vestibulocochlear. 9 is glossopharyngeal. 10 is vagus. 11 is accessory. And 12 is hypoglossal. Okay, so these are all the optic nerves, the cranial nerves, and a good way to remember what type of innervation they provide, because there can be sensory, motor, parasympathetic, and then there can be both like sensory and motor. So I'll do that one in like, I don't know, green. Okay, so there's a mnemonic that you can use for this. So it's some say marry money, but my brother says big brains matter most. And this tells you what type of nerve it is. And then parasympathetic is 3, 7, 9, and 10. And these ones you just gotta learn. But once you learn the functions, it becomes easier to remember them. Okay, so let's go through them. So that's kind of an overview of what type of innervation it's going to be providing. So first up, we have olfactory. And as we saw above, olfactory is a sensory nerve. So it's sensory, and it provides sense of smell. So if you don't have it, then you have no smell, also known as anosmia. And the olfactory nerve exits the neurocranium via the cribriform plate in the ethmoid bone. Okay, so that's basically all you really need to know about the olfactory nerve. If you're actually looking at it in a brain, you won't be able to see it like from the top. You will see olfactory tracts and then bulbs like this leading into the brain if this is the anterior and this is the posterior part. So that's the olfactory. Okay, so number 2, we're going to talk about the optic nerve. And the optic nerve, as we talked about before, is a sensory nerve because it gives you vision. So if you get rid of it, what happens? You become blind. So different forms of blindness will occur. And it exits the cranial nerve via the neurocranium via the optic canal, which is like if you have an eyeball, if you look back in the skull, you can see this little hole on like the top or upper portion, and that's where the optic canal is. That's where the optic nerve is, and that will run to the back of your eyeballs into the retina. Allows you to see. So that's really helpful, useful. Okay, so now let's move on to number 3. So that would be oculomotor. So oculomotor is a motor, and it literally tells you right here, motor. So it's motor. There's a helpful trick to remember what muscles it does. So there's a lot of eye muscles. There's just a lot of muscles overall, just too many muscles. But so you have LR6, SO4, R3. And this is like kind of like a chemical equation. Like it has like the vibe of a chemical equation. So R3 is R means the rest. So it's the extraocular muscles, except LR plus SO, and LR is lateral rectus and SO is superior oblique. And it also does motor innervation of the levator palpebrae superioris. Okay. And that is the motor function. So it also has parasympathetic function though. And what is that function? Well, it's oculo, so it's about the eyes. So it's parasympathetic to the eyes. So it would be the sphincter, papilla, pupillae. Okay, clearly I'm not the best with spelling. Pupillae plus ciliary muscles. And these are really useful for constriction of the pupil, because think about it. If you're scared and you're running, which is sympathetic, your pupils get big, dilated. You got to let the light in. But if you're chilling, you're parasympathetic, everything's calm, you're constricting the vision. So what happens if you lose these functions? So if you can't open the levator palpebrae superioris, which is the upper eyelid, you would experience ptosis, which is just drooping of the eyelid. If you can't move your extraocular muscles, then you would have diplopia, which is double vision, and also strabismus, which is cross-eyed. And then finally, if you cannot constrict your pupils, then your pupils are going to be big. So you'd have mydriasis. And this is big pupils, dilated pupils. Okay, moving on. We're powering through. Number 4, trochlear. This one, a lot of them are about the eyes for like the first like part of it, because it starts like they're in the front, the more anterior portion of the neurocranium, and then as you move back, you get towards things more in the back, and what's in the front of your face is your nose and your eyes and all that. So trochlear is, if you go back to our mnemonic, motor, wait, this should not be parasympathetic. We're 7. I just wrote it wrong. This one. There we go. Sorry. Trochlear is not parasympathetic. It's just motor. Okay. So it's superior oblique muscle is its function. It controls that. And it's just another eye muscle. It exits the cranium via the superior orbital fissure, and this is similar to cranial nerves 3 through 6, with 5 only being 5-1. So the ophthalmic division of number 5, but the rest of the cranial nerve 5 will be going through different foramen in the skull. Superior orbital fissure, if you lose it, what happens? Well, you have diplopia. Because essentially, if you just don't know, I would just guess diplopia, because if it's muscles of the eyes and you mess it up, then probably you're not going to be able to see well, because your eyes are not going to be able to like be in the same plane, or not in the same plane. They're not going to be able to like be looking at the same thing at the same time. So you're going to have double vision. So that'd be my best guess for any of those types of things. Okay, moving on to number 5. We have the trigeminal. This one is a beast. Trigeminal. Beast trigeminal. Okay, she has branches. V1, V2, V3. So V1 is the ophthalmic division. Then we have the maxillary. And then we also have the mandibular. And a way you can remember which hole in the skull they're going to go through is with the saying that Max is round and Mandy is oval. So imagine Mandy, it's a girl, being oval, and Max being round. Okay, so that helps because the maxillary division goes through the foramen rotundum, and the mandibular region goes through the foramen ovale. And the ophthalmic division goes through, as I said before, the superior orbital fissure. Okay, what are the functions? So the way I like to think about the functions is like, just like it's 1, 2, 3, you're going down the face in 1, 2, 3. So we have the top of the, I'm just going to draw a little makeshift face here. Oh gosh, that's terrible. I'm not an artist. Okay. Here's some ears. Here's some eyes. Here's some lips. Okay. Not an art major. Okay. Here we go. So the top part of the head to the eyes would be V1, and then, or 5-1, and then from the eyes to the lips would be 5-2, and then from the lip area to like the mandible is V3, and then V3 also does other things which we will talk about. So let's start from the top. So V1 is the skin sensation. So this is sensory. Oops, I should make it orange or yellow. How do I do this? There we go. From above eyes to cornea. And this is going to be important that it goes to the cornea. So just keep that in mind for later. Actually, for now, we're going to do that now. We're just going to do dysfunction right afterwards because I feel like it cements it. So if you lose function of the ophthalmic division of the trigeminal nerve, what you're going to happen is you're going to lose the corneal blink reflex. So if someone tries to poke your eye, like just touches the cornea with like a cotton swab or something, you're not going to blink. And that's a sign that something is wrong. And then also for all of these, if it's sensation and it's skin, then you're going to have either neuralgia, which is pain, or anesthesia, which is loss of sensation to the affected region. Okay. So Max, Max is round. He's V2. He's going from the eyes to the lips. This one is literally just skin sensation from below eyes to lips. And this one is also neuralgia and anesthesia to the affected region if you lose function there. And the last one is, this is where it starts to get a little different. So you have sensation, skin of mandible. And then you also have, so the tongue is interesting. So you have the anterior 2/3 of the tongue, general sensation. So this is just going to be sensation, not taste. So that's going to be really important because if you lose this, you're going to lose general sensation of tongue, specifically the anterior 2/3. And then you're also going to be losing, like, doing the anesthesia and the neuralgia to that specific region. Now, as noted, if you look at the mnemonic, it says 5 is both, because it's the words but, so it's both. So you're like, okay, well, I see motor, or sensory, I see sensory, where's motor? Well, motor is in this V3 branch. So it also supplies motor innervation to muscles of mastication. And these muscles I will cover more in my next video. These include the mylohyoid, the anterior belly of digastric, the tensor veli palatini, and the tensor tympani. And so if you lose that, then you also have difficulty chewing, because Yeah. If you can't chew, then you can't chew. So that's not good. Okay, so we're back with number 6. Finally, we're done with number 5. Honestly, getting through number 5 was such a headache. Okay, number 6, abducens. Abducens, just a little breather before we get to number 7. So, abducens is all about motor. Specifically, the lateral rectus, which is an extraocular muscle. So it kind of jumped around now because now we're back at the eyes, but it is what it is. Okay. So lateral rectus. If you lose it, then... So lateral rectus, it's lateral. So, I mean, this is... I don't know if this is actually accurate, but I know it's lateral. So if you lose this lateral muscle, then your eyes are probably going to go inwards, which is medial. So dysfunction would lead to medial strabismus, also called like internal rotation of the eyes, and then also, once again, diplopia. If your eyes are not moving together, then they're moving apart, they're growing apart. Yeah, it's just like a relationship. Okay, we're done with abducens. That's all I have to say about that one. And I already talked about how superior orbital fissure is responsible for 3, 4, 5, 1, and 6 leaving the neurocranium cavity. Okay, now on to number 7. This one is a beast. So number 7 is the facial nerve, and there's a lot of things going on here. So you can already imagine facial, yeah. So motor portion is all facial muscles of expression. So while the trigeminal provided sensation to the skin, actually being able to like smile, move your face around is due to the facial nerve. So this is the motor. And if you don't have motor function of your face, then you have facial paralysis, also known as Bell's palsy. Okay, so 7, let's go look at the mnemonic because I always forget. Facial. 7, my brother. Okay, brother is both, so we know that sensory is coming up. Okay, so there's branches. So there's the chorda tympani, and then there's also the parasympathetic branches. So the chorda tympani has sensory innervation in the sense that it has taste to the anterior 2/3 of tongue. And it also has parasympathetic stimulation of the submandibular plus sublacrimal. Oops, nope, sublingual glands. Sublacrimal, or I think it's just lacrimal. Yeah, it's just lacrimal. Is this one. So lacrimal glands. So your 7 is your tearing. Things are happening. Tears. You're crying. When you're crying, your face is moving because you're like bunching up your eyes. So it's facial muscles. And you're also, maybe you're tasting the tears, and that would be sensory. So put those all together. Salivation. A lot of fluids are flowing here. So if you don't have chorda tympani, then you do not have taste. So no taste in the anterior 2/3 of tongue. And then you also, if you don't have the sublingual glands, you have reduced salivation. Or if the innervation isn't working properly. And no tears, you have no tears left to cry. By Ariana Grande. But you don't have tears because lacrimal glands are not working. So that's loss of lacrimation. Yeah, so just making sure I got everything. Yeah, this is the only one that exits the skull. So it goes like, it exits the neurocranium via the internal acoustic meatus, and this one leaves with 8, which we'll get to next, but then it exits the actual skull through the stylomastoid foramen. So it's important to note that if the stylomastoid foramen is here, you have the chorda tympani and the parasympathetic branches up here. So if you cut off the nerve up here or down here, it will be different losses. So if you cut the nerve up at this top one, you're going to have Bell's palsy plus no tears, loss of lacrimation, plus reduced saliva. But if you just cut it at this bottom one, it's just Bell's palsy. So that's important to know because that will tell you like where's the damage if you were assessing a patient. Okay, done with 7. We're a little over halfway. Some of these will fly through them. Okay, this one is one of those fly through ones. Vestibulocochlear. She's all sensory. Literally just sensory. Sensory in the sense of hearing plus balance. So this is important. Also leaves through the internal acoustic meatus. And if you don't have it, then no hearing, plus you lose balance, so loss of equilibrium. And that's really all there is to know about it, at least for how much I have to know. So, okay, we're coming back. This, number 9, is the glossopharyngeal nerve. This guy is both. It's both motor and he's both sensory. So let's talk about the sensory. So it's the posterior third of the tongue. Taste plus general sensation. And then you also have sensation of oropharynx. Motor-wise, you're supplying the stylopharyngeus. And I always remember this because this nerve runs with the stylopharyngeus muscle. So, like, that's helpful. If you see him in an actual cadaver, you will see that is what's happening. Besides that, it also has parasympathetic function, which goes to the parotid gland. So the only the only cranial nerves that have all 3 are number 7, facial, 9 and 10. The rest of them do not have all 3: sensory, motor, and parasympathetic. Okay, so what happens if you break it? If you break it, you buy it. If you get rid of the stylopharyngeus, that's like back in like the throat area. So first parotid, that's reduced salivation. Parotid gland does salivation. You are going to lose sensation in your tongue, plus taste. And you're also going to have trouble swallowing, which is called dysphagia. And then finally, this is the big one. You're going to have loss of gag reflex. So this is a way, knowing the reflexes is important because this is how you can actually like diagnose a patient in clinic. You can see if they have a reflex. If they don't, then you're like, okay, well, that's not good because something's wrong. Okay. That was 9. 10. Vegas. Vegas. Okay. Vegas is also both. She's one of the special ones where she has all 3. So sensory wise, oh yeah, and glossopharyngeal, so 9, 10, and 11, they all exit the skull or the neurocranium via the jugular foramen. 11 is special, but we'll get to that when we get to that. Okay. So sensory, the vagus nerve innervates sensations of the neck, thorax, and abdomen viscera. Plus taste of epiglottis. And palate. Motor-wise, the muscles of the palate, the larynx, and the pharynx. And then has parasympathetic as well, and that's to the viscera of, and I call them NAT. Neck, abdomen, thorax. Dysfunction would be trouble swallowing because you're not able to move the larynx and the pharynx super well. Trouble speaking. Decreased HCl production because parasympathetic is like rest and digest, and of the abdomen is where the stomach is. You would also have loss of visceral reflexes. Decreased GI motility. Sagging. Soft palate, since it provides muscle innervation to the palate. Plus uvula, it's part of that region. Tachycardia, so fast heart rate because the vagus nerve slows down the heart. And aspiration pneumonia. If you're not able to sense what's going on in like your throat area, that obviously could lead to food being stuck there and you would never know. And you can tell which side is affected because the uvula will deviate to affected side. Okay. That's everything. The vagus is a big one. Literally, okay, if you ever see a nerve below the neck, that's a cranial nerve, it's probably the vagus. Just word of advice. Go with vagus. Okay. Accessory is number 11. Accessory is motor to trapezius plus sternocleidomastoid. And if you have dysfunction, you're going to have weakness with shoulder shrugs, since that's what the traps do, plus turning head. And important to note that cranial nerve 11 comes up through the foramen magnum and then goes through the jugular foramen and then out. So this is one of the only ones that does that, or is the only one that does that, to my knowledge. You can see it going like through the foramen rotundum if you look at it on a cadaver, and that's how you know that's cranial nerve 11. Okay, and then finally, cranial nerve 12. We've made it all the way through. Is the hypoglossal. And thank goodness it's only motor. It's literally just the tongue muscle. Well, there's a lot of them, but except palatal-glossus, because palatal-glossus, if it has the word palate in it, it's probably vagus, because the vagus does the palate stuff, innervation. Okay. What else? So if it's damaged, the tongue is going to deviate to the side that's damaged when protruded. And it exits the cranial vault via the hypoglossal canal. And that's it. Thank you so much for listening to my video. Hopefully it was helpful. Hopefully it wasn't super confusing.